What's up, everybody? Look, just letting y'all know, just y'all remember that I'm doing this pre-recording so everybody can be weather-wise with some weather moving in for Tuesday night. So just wanted to make sure that this was available for you guys so that y'all could concentrate on the weather, but still be able to take the class whenever y'all had an opportunity. So today, tonight, this evening, tomorrow, whenever you're watching this, it's going to be over about trauma. So here we talked about again, this is how trauma applies the fundamental knowledge to provide basic emergency care and transportation based on the assessment findings for an acutely injured patient. We're going to go over the pathophysiology assessment and management of trauma patients. We'll talk about how we score our patients, what our rapid transport and what our destination issues, and transport modes. In a multi-system trauma, we want to talk about the recognition of management, how we're going to treat the multi systems of these traumas, what all is going to be partaked into that. We'll do the patho assessment and the management of a multi-systems trauma and a blast injuries. For people younger than the age of 44, traumatic injuries are the leading cause of death in the United States. Traumatic emergencies occur as a result of physical forces applied to the body. Medical emergencies occur from illnesses or conditions not caused by an outside force. Evaluation of the MOI for the trauma patient will provide you with an index of suspicion with different types of serious and/or life-threatening underlying injuries, my bad. Index of suspicion is your awareness and concern for potential serious underlying and unseen injuries. We're going over injury and trauma. So traumatic injuries occur when the body's tissues are exposed to energy levels beyond their tolerance. So that's more than what we deal with on a day-to-day basis. Us walking, moving, those are our normal tolerances that we deal with on a daily basis. Mechanisms of injuries describe forces or energy transmission acting on the body that will cause injury. Three concepts of energy that are typically associated with injury. I would write these down, mark it, highlight it, go over it, remember it. This is potential energy, kinetic energy, energy of work, and energy can be neither created or destroyed. It only can be converted or transformed. Remember, your three concepts of energy are potential energy, kinetic energy, and energy of work. Work is defined as force acting over a distance. Forces that bend, pull, or compress tissues beyond their inherent limits results in the work that causes injury. Kinetic energy, you want to write this down again, folks. Kinetic energy is the energy of a moving object. This reflects the relationship between the mass or the weight of an object and the velocity, speed at which, I think that's supposed to be speed, at which it is traveling. Kinetic energy equals half mass times velocity squared. Potential energy that is product of mass or weight is the force of gravity and height. The most associated with energy is of falling objects. Let's see if I can fix something real quick on my screen. All right. Mechanism of injury profiles. So different types of MOIs will produce many types of injuries, which we know that we've talked about that already. So non-significant MOIs is an injury to an isolated body part. A fall without the loss of consciousness are some examples. Significant MOIs, injury to more than one body system, which is a multi-system trauma, falls from height, motor vehicles and motorcycle crashes, car versus a pedestrian or bicycle or motorcycle, gunshot wounds, and stabbings. Traumatic injuries can be divided in two separate categories. We have our blunt trauma and penetrating trauma. So blunt trauma is the resort of force to the body that causes injury without penetrating the soft tissue or internal organs and cavities. So that's like me taking a bat and hitting you in your stomach. It's not penetrating, it is a big blunt object hitting you. Now, penetrating trauma causes injury by objects that primarily pierce or penetrate the surface of the body and cause damage of soft tissues and or organs, and body cavities. That's like me taking a knife and stabbing you. Either type may occur from variety of MOIs. Blunt trauma results from an object making contact with the body. Motor vehicle crashes and falls are the most common MOIs. Be alert to skin discoloration and pain, as they may be the only signs of blunt trauma that we see. Maintain a very high index of suspicion for hidden injuries. Here we have a picture of just a normal crash. This is a head-on. The big thing that gets me is you see that you do have airbag deployment. I don't see any spidering right up here in the window, so that makes me know that nobody hit their head. Looks like this is broken down here on both sides, so potentially that come from the some other object, or just the force was created and broke that. Can't see any other injuries, but we know it's a head-on collision, and those are pretty rough. A crash typically consists of 3 collisions: car against another car, tree, or object. By assessing the vehicle that has crashed, you can often determine the mechanism of injury. Now, looking at that probably means that they went, they have some sternal issues, some abdominal issues, and maybe their knees hurt. Probably going to say their arms and wrists, potentially from the airbag deployment, and they're probably going to have some type of red marks to the forehead if their head struck the airbag. So here we have a side impact. Passengers against the interior of the car, which is a kinetic energy produced by passengers' mass and velocity is converted into the work of stopping his or her own body. Common passengers' injuries include lower extremity fractures, rib fractures, and head trauma. So here on this one, you can't really tell. If I can find my cursor. So I don't know if any of you already know this, but this is the A post. This post that's right here between the driver and passenger is going to be your B post, C post, and it goes on and on. If you have multiple, like a school bus, it can be A, B, C, D, all the way through J. So here you're unable to really tell if the seat was broken by the impact or it was potentially cut by the jaws of life. So that you can't tell. There is some heavy blood here. So you can tell that there's some heavy injuries here. Seeing how this is broken, most likely tells me that it was a knee struck this area here. Even with the seatbelt pulled in, if they cut the seatbelt, it's automatically going to ratchet in. But you notice how there's nothing over here stuck in the where the seatbelt goes. So that tells me that there was no seatbelt worn at this time of injury. Again, you can't tell for the spidering since there is heavy damage here to the top. So we don't know if there was any type of spidering or anything that caused that. Passenger's internal organs against the solid structures of the body. So internal organs may be as obvious as external injuries, but they are often more life-threatening. So in the picture here, you see that his head has struck the glass. So you have the coup contra coup effect. So he hits it, comes back, hits it again, and then the brain, when the body stops, does still stay in motion and hits the front of the skull again. Now, you're obviously going to have a head injury. We're not going to see the obvious bleeding and all that from right here inside the brain because it's protected by the skull. But you're going to be able to start noticing some things on how his speech may be, his motor, hand movements and all that may be different. So be cautious of those things and pay attention and look out on the advancement of those signs as soon as they start arising. Significant MOIs are suggested by death of an occupant in the same vehicle, severe deformity of a vehicle or intrusion to the vehicle, which means intrusion if there's, so the vehicle normally, let's say they measure 5 feet wide. Well, now if you look at the car and the car is 2 feet wide, that's considered intrusion because it shrank the size of the vehicle. Moderate intrusion from a lateral accident, severe damage from the rear, crashes in which rotation is involved, which means they spin in circles, and ejection from the vehicle. Frontal crashes, evaluate the supplemental restraint system, determine whether the passenger was restrained by full and properly applied three-point restraint. Determine whether the airbag was deployed. Seat belts and airbags are effective in preventing a second collision inside the motor vehicle. Seat belts may decrease the severity of the third collision, and airbags decrease the severity of deceleration injuries and decrease injuries to the chest, face, and head. Despite airbags, suspect injuries to extremities resulting from the second collision, internal organs resulting from the third collision. Children shorter than 4'9" should ride in the rear seat. Remember that if the airbag did not inflate during the accident, it may still deploy during the extrication. So you always have to take precaution anytime that you're dealing, when you start working on the inside of a vehicle, and it's been minutes later since you arrived and there's no big airbag deployment, you still have to be cautious because there still may be some deployment up to 30 to 40 minutes after the battery has been disconnected from the vehicle. Here's a picture of the supplemental restraints. You can see that the seatbelt did do its job, but it did cause a lot of injuries. Remember that supplemental restraints can cause harm whether they are used properly or improperly. Hip dislocations may result if the seatbelts are worn too high. Internal injuries can occur when the seatbelt is worn too high. I said that backwards a while ago. So hip dislocations may result if seatbelts are worn too low. Internal injuries can happen when the seatbelt is worn too high. Now that I've said that right, we can move on. Lumbar spine fractures are also possible, particularly in children and older patients. Look for contact points between the patient and the vehicle as you perform a simple, quick evaluation of the interior of the vehicle. So look here. So this is a rear end crash. So most injuries that you're going to see here are whiplash type injuries, particularly in the absence of an appropriately placed headrest. So the body's going to go forward and come back and jerk. So you're going to have those injuries. I mean, that little car, didn't like there was much protection back there anyway. It was like it was all plastic. So as the body is propelled forward, the head and neck are left behind. So acceleration type injuries to the brain are possible. Passengers in the back seat will, wearing only a lap belt, have a higher incidence of injuries to the thoracic and the lumbar spine. 2 seconds. Lateral crashes, a common cause of death associated with motor vehicles. So a lateral crash is the car is typically struck above the center of gravity and begins to rock away from the side of the impact. This causes a type of lateral whiplash in which the passenger's shoulder and head whip toward the intruding vehicle. So it's like here, if it's struck here on this picture, they're going to hit right here, and the patient's head's going to actually hit the window. Or if it's intruding into the vehicle, you can actually have where the head makes contact with the car, the intruding car itself. A vehicle struck from the side is usually struck above its center of gravity. It begins to rock away from the side of impact, results in the passenger sustaining a lateral whiplash injury. If there is sustainable intrusion into the passenger's compartment, suspect a lateral chest and abdominal injuries on the side of impact. Also suspect possible fractures to the lower extremities, pelvis, and ribs, and organ damage from the third collision. Rollover crashes. Large trucks and sport utility vehicles are prone to rollover because of their higher center of gravity. Injuries depend on whether the passenger was restrained. The most common life-threatening event in a rollover is ejection or partial ejection of the passenger from the vehicle. Even when restrained, the passenger can sustain severe injuries. On a rotational crash, which means they're spinning, are conceptually similar to rollovers. The rotation of the vehicle as it spins provide opportunities for the vehicle to strike objects such as utility poles. All right, so car versus pedestrian. So some of the injuries we're going to see here is graphic and apparent. There can be also serious unseen injuries. You should determine what potentially the speed of the vehicle was, whether the patient was thrown in the air and at what distance, and the surface the patient landed on, and whether the patient was struck and pulled under from the vehicle. So let's say that I'm driving down the road and I hit this guy, and he hits the hood of the car and goes down and under. Well, most of the time that's a short individual, because your taller individuals are going to go up and over. The reason why we want to know if they go down and under is because they now potentially can have crushing injuries associated with multiple fractures, broken bones. I mean, we're all going to deal with all these injuries. We just need to be more cautious and understand what type of injury that they sustain from the vehicle versus pedestrian in itself. Evaluate the vehicle that struck the patient for structural damage. Always request ALS backup. Any of these patients who are thought to sustain a significant MOI. Car versus bicycle. Evaluate the MOI in much the same manner as the car versus pedestrian. Evaluate the damage to and position of the bicycle. If the patient was wearing a helmet, inspect for damages. We always want to make sure that we take that helmet with us to the hospital. Presume that the patient has sustained any injury to the spinal cord or spinal column or spinal cord until proven otherwise at the hospital. Spinal mobilization must be initiated and maintained during the encounter. Car versus motorcycle. Helmet does not protect against severe cervical injury. Leather or abrasion resistant clothing will protect against road abrasions, but not against blunt trauma or secondary impacts. And boots are important for these too. When assessing the scene of a motor vehicle or motorcycle crash, look for deformities to the motorcycle, side of the damage, side of most damage. So we want to know what side that they were struck on. Distance of skid in the road, deformity of stationary objects or other vehicles, extent of location and extent and location of deformity in the helmet. So if there's any type of injuries to the helmet, we want to know potentially, did it strike the concrete? Did they hit an object as they were flying? Because we can also have other potential trauma to the head from that motor vehicle. And that's the reason why helmets are very important. If they're off, we want to make sure that we get the helmet and look at it and take it with us to the facility. There are 4 types of motorcycle impacts. You have your head-on crash. The motorcycle strikes another object and stops its forward motion while the rider continues his or her forward motion until stopped by an outside force. You have your angular crash. The motorcycle strikes an object and another vehicle at the angle so that the rider sustains a direct crushing injury to the lower extremity between the object and the motorcycle. Obviously, we know what an ejection is. Controlled crash is a technique used to separate the rider from the body of the motorcycle, and the object to be hit is referred to as laying the bike down. They teach that a lot in motorcycle classes, like for law enforcement, anything like that. They want to tell them, or I don't really know how you can teach it, but they try to teach them to lay the bike down and push themselves away from the motorcycle when it's starting to slide. All right, so falls. The injury potential of a fall is related to the height from which the patient fell. The greater the height of the fall, the greater the potential for injury. A fall from more than 20 feet is considered significant. Internal injuries pose the greatest life threat. Patients who fall and land on their feet may have less severe internal injuries because their legs may have absorbed much of the energy of the fall. However, they may have serious injuries to the lower extremities and pelvic, along with spinal injuries. So as you can see here, is they're absorbing the fall here, and it's end up going to make the pelvis and spine issues have issues back here. All right. Also take into account the height of the fall, the type of surface struck, and the body part that hit first, followed by the path of energy displacement. Here comes the fun one. Any type of penetrating trauma is the second leading cause of trauma in the United States after blunt trauma. Low energy penetrating trauma may be caused by accidentally by impalement, intentionally by a knife, ice pick, or other weapon. With low energy penetrations, injuries are caused by the sharp edges of the objects moving through the body and or therefore close to the object's path. Knives may have been deliberately moved around internally, causing more damage than the external wound suggests. So if I stab you and I start shaking it around, or what type of blade, if I have like a sharp and then it has like a cutting like the jagged parts on the end where it's like a cutting blade, those can also cause more injuries. The medium and high velocity, which is speed penetrating trauma, is the path of the projectile. Usually a bullet may not easily be predicted. The bullet might flatten out, it may start to tumble, or even ricochet within the body before exiting. The path of the projectile takes its trajectory, and fragmentation will increase damage. So here's kind of a cool picture. I like this a lot. Cavitation results from rapid changes in tissue and fluid pressure that occur with the passage of the projectile. Temporary cavitation injury results from a stretching of the tissues that occur with pressure change, and permanent cavitation injuries result closer to the bullet's path and remains after the projectile has passed through the tissue. So you see here, we have the bullet entrance and exit. It can start to tumble here, but this is the temporary cavity because it swells up because of the pressure that's coming through. And right here, as you see how it's way smaller here, but this is the permanent cavity that's going to be created as it exits the body. The relationship between distance and severity of injury varies depending on the type of weapon involved. Air resistance, often referred to as drag, slows the projectile, decreasing the depth of penetration and energy of the projectile and thus reducing damage to the tissues. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile itself. This is one reason that exit wounds are often more times larger than entrance wounds, as we just showed you on the other picture. The energy available for a bullet to cause damage is more a function of its speed than its mass. The important factor of the seriousness of a gunshot wound is the type of tissue through which the projectile passes. Sorry about that, y'all. Let's see here. So this is recognize and develop problems in trauma patients. I'll let y'all look at that for just a second. It's also in your book. Give me just a second, y'all. All right, so y'all got to see the chapter, the cover there. So let's move on. So blast injuries. So we haven't seen many of these. You do see them as the bottom bullet right there. It says terrorist activities, chemical plants, but we don't have many mines anymore. I mean, we do in the kind of the north, but we don't really, they're so overly regulated and you don't really have those as much as you used to. But in blast injuries, so this figure slideshow tells you the mechanism of injury. So you have your primary blast. Let's get your primary blast here. This is your secondary blast issues. Injuries to the missiles being propelled by blast force. You have your tertiary blast, which is injuries due to the impact of another area. And your quaternary blast is collision injuries such as burns, crushing injuries, toxic inhalations. Most time you have your primary, secondary, and tertiary. I'm not real familiar with the quaternary blast because they really harp on the 1, 2, and 3 injuries. So people who are injured in explosions may be injured by 4 different mechanisms. Primary blast injuries. So there are different, there are due entirely into blast injuries itself. Damage to the body is caused by the pressure wave generated by the explosions. So the secondary blast is damage to the body results from being struck by flying debris. And the tertiary injury is when the victim is hurled by the force of the explosion into a stationary object. That's like me if I'm, let's say, so let's use this. In the Boston bombing, which is kind of the recent one that we should all kind of remember, they had the cooker pot, and when it exploded, they had bits and pieces of bolts and washers and all that. So that is part of your secondary. And then your tertiary is from you being picked up and thrown to the ground. So those kind of your injuries in itself, the 1, 2, and 3. The initial injury is the shock wave and the pressure wave that you receive. So those are the different types of injuries that we're going to see in there. So the miscellaneous blast, which is your quaternary, I'm not going to say that right, but burns from hot gases or fires are started by this blast. Respiratory injury from inhaling toxic gases. We have crushing injury from the collapse of a building, suffocation, poisoning, or other medical emergencies. Contamination of wounds from the environment, chemical or toxic substances. Meaning most patients who survive an explosion will have a combination of 4 types of injuries. That is 100% true. Tissues that are at risk. Organs that contain air, such as the middle ear, lungs, gastrointestinal tract, are the most susceptible to the pressure changes. The ears are the most sensitive to blast. Most of the time after a blast injury, you do have a lot that complain of unable to hear. They have deafening effects that affects them for quite a while. They may get their hearing back over time, or they may not get it all because their eardrums are just, they can't take the pressure, just blew them out. So pulmonary blast injuries are defined as pulmonary trauma that has result from short-range exposure to the detonation of explosives. So a pneumothorax is common injury and may require emergency decompression in the field. One of the most concerning pulmonary blast injuries is an arterial air embolism, which occurs on the alveolar disruption with subsequent, it has an air embolism into the pulmonary vasculature. So this can produce disturbances in vision, changes in behavior, changes in the state of consciousness, and a variety of other neurologic signs. Solid organs are relatively protected from shockwave injuries, but may be injured by the secondary missile or hurled body. Neurologic injuries, such as head trauma, are common cause of death from blast injuries. Extremity injuries include traumatic amputations. Those are very common. You can see partial amputation or full amputation. You saw a lot of those in Boston. That's one of the most recent bombings that we could speak about. You can have injuries that, small, like you say, your fingers, your hands, toes. Those are kind of the same injuries that you may have full and partial amputations. So multi-system trauma, this involves more than one body part, like we've talked about. So you can have the head and spinal cord, chest and abdominal trauma, chest and multiple extremity trauma. You must alert med control and transport very rapidly for this. Multi-system trauma patients have a high level of mortality and morbid. Why can I not say these words today? Whew, y'all, I am sorry about that. Golden principles of pre-hospital trauma care. Your main priority is to ensure your safety, the safety of your crew, and the safety of the patient. Determine the need for additional resources or equipment and evaluate the MOI. Identify and manage life threats, then focus on patient care. Hemorrhage control has the highest priority. Assess and manage the airway, including ventilatory support and high flow oxygen while maintaining appropriate spinal restrictions in the second priority. Ensure that other shock therapy is completed. Protect the spine and proceed with spinal mobilization if indicated. Transport the patient immediately to the most appropriate facility. In most patients with multi-system trauma, definitive care requires surgical intervention. On-scene time should be limited to 10 minutes or less. During transport, try to obtain a sample history and complete a secondary assessment. So I'm going to say this right here. Make this a priority to get ALS, intercept, or air medical support, depending on your location of the facility. Patient assessment. When you're caring for a patient who has experienced a significant MOI and the patient is considered to be in serious critical condition, you should rapidly perform a physical exam. With a patient who has experienced a non-significant MOI, focus on the chief complaint while assessing the patient as a whole. Injuries to the head. Disability and unseen injury to the brain may occur. Bleeding or swelling inside the skull is often a life threat. Include frequent neurologic exams of your assessment. So what I'm going to do here is talk to them. Get them to talk to me. I need them to answer simple questions. Some patients will have obvious signs of symptoms until minutes and hours after the injury has occurred. Airway problems may result that could quickly become serious life threats. Your assessment must include frequent physical examinations along for looking for decap BTLS in the neck regions. Also assess for JVD, which is jugular vein distension and tracheal deviation. Swelling may prevent blood flow to the brain and cause injury to the central nervous system. A penetrating injury may result in an air embolism. A crushing injury to the upper part of the neck may cause the cartilage of the airway and larynx to fracture. I've never seen that, but I want to see it, but I hate the outcome of that patient. Injuries to the chest. The chest contains the heart, lungs, and large blood vessels. I hope we know that by now. Many life-threatening injuries can occur here. Broken ribs may hinder breathing. Bruising may occur to the heart and cause irregular heartbeats. Large vessels of the heart may be torn inside the chest, causing massive unseen bleeding. Air may collect between the lungs and tissue and chest walls, known as a pneumothorax. The collection of blood in the chest is called a hemothorax. A penetration or perforation of the integrity of the chest is called an open chest wound. If this is left untreated, shock and/or death will result. It is imperative that you assess the chest region every 5 minutes. Assessment should include a decap BTLS, lung sounds, and chest rise and fall. The abdomen contains vital organs that require a very high amount of blood flow to perform functions necessary for life. Solid organs may tear, lacerate, or fracture when they can cause serious bleeding into the abdomen. Solid organs include the liver, spleen, pancreas, and kidneys. Hollow organs may rupture and leak toxic digestive chemicals, causing the possibility of a life-threatening infections. Hollow organs include the stomach, large and small intestines, and a urinary bladder. The rupture of large blood vessels can cause serious unseen bleeding. Management and transport decisions. So your scene time needs to be very limited in any type of trauma. We want to keep it to 10 minutes or less. If your patient is critically injured and they have dangerous MOIs, decrease the level of consciousness, threatens to the airway or circulation, these patients need to be transported ASAP. Patients who are very young or old or have a chronic illness should be considered to be a very high risk. Destination selection. How am I going to make the appropriate selection? So trauma centers are classified into levels 1 through 4, the level 1 having the most resources. And I highly suggest in your area that you know these locations. Level 1 facility provides every aspect of trauma care from pediatric to geriatric. Level 2 facilities provide initial definitive cares. A level 3 provides assessments, resuscitation, emergency care, and stabilization. And a level 4 only provides advanced trauma life support. So you see there's a big difference. Some places, and you hear them call those Band-Aid stations, they may just be a level 3. And what they do is they can help stabilize them because they're the closest facility. They still have a medical doctor there. They can provide the stabilization and then transport of a patient again to a level 1 or 2, because they may have an air pad where the helicopter can come and land and get higher, they can get transportive care a whole lot faster. The Association of Air Medical Services, AAMS, and MedEvac Foundation internally identified the following criteria for the appropriate use of emergency air medical services for trauma patients. There is an extended period required to assess or extricate a remote or trapped patient. The distance to the trauma center is more than 20 to 25 miles. The patient needs ALS care, and there is no ALS level ground ambulance service available within a reasonable time frame. Traffic conditions or hospital ability makes it unlikely that the patient will go to the trauma center via ground ambulance with the ideal time frame. There are multiple trauma patients who will overwhelm resources at the nearby trauma centers. EMS systems require bringing a patient to the nearest hospital rather than bypassing facilities to go directly to a trauma center. This may add delay to receiving definitive surgical care and the mass casualty incident. So also certain services have their own criteria. One of the biggest ones here in the state of Mississippi, Mississippi MedCom, UMC AirMed, you call into MedCom and they can help you talk through that and see if you have activation or not. And they can activate, they have 4 helicopters throughout the state and can cover the entire state. And it's still a delayed response, but they have certain of their own criteria that they can help follow. Trauma centers are categorized as either adult trauma centers or pediatric trauma centers, but not necessarily both. Our level 1 trauma center here in Mississippi, it has a adult ER entrance and a pediatric ER entrance. They are separate facilities, but they are still the same hospital. Their ERs are separated literally by 40 feet. So that's how they separate those. And I think it is 12 or higher goes to the adult facility and 12 and lower go to the pediatric side. So we obviously know we have different types of transports. We have our ground units, we have our air units. Most of the time in your air units, they have nurses and paramedics. I have seen some services fly some MDs. We've had several MDs fly to scenes to do a field amputation before. That was very rare. I was part of the very first call in the state of Mississippi that happened on. So here as you see management transport destinations. So we have our step 1, we got our GCS. If it's less than 13, the systolic blood pressure is less than 90. The respiratory rate is less than 10 or greater than 29 breaths a minute. That indicates that indicates a transport to the trauma center. You may be able to bypass steps 2 and 3 to get to this facility. You may be able to contact med control, but this is a very good diagram to kind of know, understand, and just have this in the back of your mind. As a new EMT, this can help you make those decisions. I highly suggest you guys get a field guide, a BLS field guide. There's multiples out there. Do your homework, do some reading. You can look on Amazon which ones have the best ratings and all that. But those field guides are phenomenal. They can help you out in a pinch and give you a vast full of knowledge. Some special considerations. The number one thing is the most important, y'all. Remain calm throughout this entire thing. You are going to poop in your pants, but don't let them see that this is a traumatic event for you, okay? Complete an organized assessment. Make sure you do the same assessment for every single patient every single time. If it looks nasty, it is nasty. Correct life-threatening injuries. If their ABCs are messed up and you put your hand over that penetrating object in their chest and it helps them breathe better, keep your hand there. If there's a hole in their chest, put a sucking chest wound. Put a seal over it. Three-sided bulky dressing over there. It helps protect that. And then do no harm. If you're considering calling ALS, you should have already called them. You need some assistance. It's okay to say, I need help. Ask early and ask from the right times. Don't call wolf, but at the same time as ask for assistance when it's needed. Guys and gals, this is the end of the class. Again, I hope everybody's weather safe. They make it all fine. Tuesday, everything's okay, but here's your class code. This will allow you to take your test. Your test will be unlocked for you at 10 o'clock on Tuesday night, like normal, no other changes. If anybody has any issues, weather problems, power outage and all that, please message me as soon as you can, so that way I can get you an extension on your test. And that's it for me, guys. I hope y'all have a good week, and I will talk to y'all later.